So one really unresolved problem of CAR T-cell therapy is how do we distinguish between early infections and cytokine release syndrome in the first 10 days after CAR T-cell infusion. So we've previously demonstrated that almost 85% of all CAR T-cell patients receive broad-spectrum IV antibiotics in this time, and we would really like to have some type of tool that helps us identify, is this early fever relate to an infection or CRS? And so to do this, we performed routine and exploratory serum proteomics, and we found that patients that developed severe infections, and we did so-called index event analyses. So we look at inflammatory markers the day of a certain event, and then the 3 days prior and the 7 days after. And we find that patients that developed early infections, as opposed to CRS, they had higher levels of serum procalcitonin. And so this is a cohort about 62 patients where we longitudinally assessed serum markers such as procalcitonin, interleukin-6, ferritin, CRP, and so forth. Whereas CRS patients, they had higher levels of interleukin-6. And so we asked the question, well, what happens if we integrate the dynamic change in procalcitonin at time of first fever together with the baseline probability of infection that is conferred by the CAR-HEMATOTX score? And when we then look at how do we discriminate between early infections and CRS, when we only use procalcitonin or we only use the CAR-HEMATOTX score, it wasn't as good as when we combine the two. And that brings us to the HEMATOTX 10 score, which essentially is an integration of both the baseline HEMATOTX score and an elevation of procalcitonin at day of first fever. And this actually discriminated quite well between early infections and CRS. And follow-up studies that we've now performed, we were able to independently validate this in a larger cohort of patients. I think the other important aspect of this abstract is that we showed in exploratory serum proteomics using the Olink platform across serial measurements in about 55 patients. We found that the patients that developed infections, they already had profound immune deficits prior to therapy initiation. I think what that highlights is that the same factors that predispose patients for poor treatment outcomes probably also predispose for toxicity, such as early infections. And we hope that scores such as the HEMATOTX 10 score may help us when we have that patient developing that fever in the first 10 days, that we may not, at least in the low-risk patients, we may wait a little bit on giving this patient that broad-spectrum IV antibiotic, which has deleterious effects also on the gut microbiome. Whereas the high-risk patient, the patient that has a high HEMATOTX 10 score, likely needs IV anti-infective therapy, and the probability of an infection is higher in these patients.